right, welcome back. I'm your host, Michael Stamatinos of the Advancing Healthcare Innovation Show. And if you're new to us, we're super excited to have you here. We also happen to be crazy passionate about healthcare innovation and adoption. And if you're new to us, if you're first time tuning in, let me tell you a little bit about what we're trying to do here. So we're a healthcare innovation company. We're focused on bringing stories of innovation within the healthcare space to life. And our aim is highlighting real people that are truly innovating within our space and give them a platform to basically share their stories with the world. Now, we've had an incredibly action-packed year so far with some incredible interviews that have happened over the course of this year. If you haven't checked out any of those after this interview, I highly encourage you to go into our library, subscribe, check them out, and then for any new ones that come out, you'll be notified. So without any further ado, I'd like to welcome our next guest, Dr. Aashish Shah, who's the Corporate Vice President of Strategy, Product Innovation, Payer Contracting, and Alignment at HCA Healthcare. Dr. Shah, welcome to the show.
Thanks, Michael. Really appreciate being part of this.
Yeah, so it sounds like you've got like 4 jobs. So
yeah, I've got a great title. It is somewhat of a misnomer, but really, it's a recognition that for HCA, as part of an overarching arc over the last 2 or 3 years, that we need to make the transition from being simply a hospital company to a healthcare company. With that said, we know where our core is. We're not going to be, Intermountain Health. We don't want to be Geisinger. We know what we do well, and we're going to do really well with that. But we are evolving. As you said, it's been a crazy couple of years, certainly in the innovation space. And it's allowed us to think through not only how do you get through the last 3 years and continue to get through what was the last 3 years, but what does the future look like? And that optic of what the future looks like has completely changed through the lens of a post-pandemic environment. And hopefully we can say a post-pandemic environment. But my job, simply, great title, fancy title, but here's what it reduces down to is I'm the only physician within payer contracting alignment, which is an unusual feature. And my job is to help HCA think through how do we turn our relationships with payers from what is a transactional periodic event, contracting cycles, to something more transformative, that's something that looks at alignment, integration, so that when it comes down to doing those contracting events, the totality of our relationship is appreciated. But quite frankly, it is the recognition that payers are our lifeblood and we need to partner with them. And quite frankly, we have a lot of alignment. We want the same things in general. We struggle as large organizations to prioritize those and to partner. So first and foremost, to partner with our payers directly, indirectly, if you would, through thinking through their client base, the employers, and how can we appeal to them and create solutions that these payers can deploy. But it's really 4 things. My job is to go out and proselytize the value that we have. It's to take their perspective internally, and I like to use alliteration, as we start to continue to build solutions and not just service lines. It's to partner with the best and brightest as we do build those solutions. We don't have all the parts and pieces, whether it's a technology, a platform, a device, a service. Who do you partner with? How do you partner with them? And then how do you deploy that through a large footprint like HCA? And then finally, the connection to contracting is if you can do 1 through 3 pretty effectively, how do you monetize that value? So it's an interesting role. It is 4 or 5 different roles, all in an amalgam together. But I think at its core, it is the essence of innovation, which is simply how do you do what you do well and do it differently and adapt it?
how do you do well and do it differently and adapt it? Absolutely. There's a sense of being able to be nimble and move quickly. Do you find that in big companies that's easier said than done? And how does HCA, which is let's just call it, it's the white elephant in the room. How do you guys stay nimble? How do you guys keep moving forward?
Yeah, I've learned over the last 3 years. I've been in lots of large organizations. I've been in state entities, private sector, public sector. And I don't think any one of them would argue vociferously that they're nimble. There's a certain amount of largesse, if you will, to these companies. In our respect, nimbleness is twofold, right? It's the literalism of being nimble. How do you pivot when the winds change? What's the business model that you have to adapt to? But nimbleness is also, I think, in our case, more so than most. And I think our our kind of financial performance of the last 3 years underscores that, is how do you pivot where necessary in terms of a business model, in terms of cost containment, in terms of prioritization. Now, those ultimate pivots don't happen overnight, but the recognition of that you need to pivot, and the identification in which direction are the things that I would say make us nimble. But like any other large organization, it takes a large group of people to steer in any given direction, and you have to have unanimity of purpose and unanimity of activity, and that can be a challenge. But I think the one thing we've demonstrated is we organizationally, through our mission, through our view, through our provision of care, see the world in unison. So it's a little easier for us to make that move when necessary. What we did during COVID, how we supported our staff and our physicians, how we went into an expense management mode, and how we're emerging out of that, I think are all examples of that. So when you ask me about staying nimble, it's not in that traditional sense, but it's this immediate recognition of what levers need to be pulled and what priority order to stay operational, to stay in business, and to be able to serve the public at large and the patients that need us.
And when it comes to kind of partnering and finding alignment with the payers, is there a level of expectation in terms of being able to maneuver through difficult circumstances? I guess, to what degree are you able to really be innovative, and do they define innovation in the same facet as how you guys define it at HCA? I guess, how do you kind of find that alignment there?
Yeah, great question. I would like to say oftentimes, at least with the payers, we are aligned on what innovation means. And let me digress for just a second and be introspective. My role as a physician is to help take a wide expanse of innovation and narrow it down into what you'd expect is more clinically focused than anything else.
That's right.
But with everything I look at from an innovation point of view, and I'll share with you my view of innovation, which I think is going to be a little bit different than others. With everything I do, I think about it from an administrative burden, from a cost of care and quality, and from kind of the measures that matter, the metrics that matter. So I'm always thinking about these three things, which tend to be a multimodal view. There are things that are important to us, there are things that are important to our payer partners, but in the collection, they're the things that we care about collectively. They care about having less administrative burden. We care about less administrative burden. They care about ultimately cost of care and quality. I care about the same thing. And then there's certain measures that are the literal measures that moving those needles really matter from a financial point of view, from a clinical point of view, from a business model point of view. So whenever we think through how do you partner, we're always thinking about, at least from my end, on a view, and I should have said this on the onset, I come from the payer world. So I'm a payer guy inside integrated delivery system mindset. So I'm always trying to think like a payer, act like a payer, and just do it internally. And so we are often more aligned than not. But another issue we share, or another opportunity we share, is while we're aligned and we want to both get to that finish line, we struggle with taking that first step. Again, going back to the large organization, the large successful organizations, right? Payers are successful in their own right, and integrated delivery systems and systems like ours are successful in their own right. But we're successful because we've adhered to generally a model that works, right?
Yeah.
And the challenge really is anything that is not focused on the core tends to be viewed as a distraction to the core. And so anytime you want to go another finish line or move the needle or innovate, whatever phrase you want to use, there's the reality that is somewhat, kind of moving away a little bit from the core business, or at least contemplating different, and that can be distracting. So we all kind of know where we want to go, which is a general vicinity that we all share. We know the path in that direction, but we struggle with that literal first step. And so I view my job as kind of trying to help the reticence of my payer partner, and then to take their view and kind of edge a little bit up with our reticence to say, you know what, this is mutual trust. We're just going to take those first steps together. But it is hard. It's interesting. I think at first blush, if you ask a bunch of people, a bunch of physicians, a bunch of executives, payer versus provider, you'll get this wide chasm of they don't get us, they don't understand us, they don't like us, they're against us. And the truth is, there's a little bit of probably gamemanship that's going on both sides, but we're more aligned than we think we are. And even more post-COVID, we're struggling in the same ways, particularly with nursing and physicians. And so we share the same pain points. We were aligned, we're more aligned. So this is actually the right time to even contemplate how do you partner better with the payer? And they're actually more interested in that, I believe.
So talk about that for just a second. When it comes to workforce, there seems to be, a wide range of issues across the country. How have you guys tried to approach that from an alignment perspective? What's worked and what are some lessons learned?
Yeah, there's a lot of lessons learned, and we're still learning those lessons, right? I mean, at the end of the day, the non-clinical and clinical staffing has been a challenge, right? It's known well outside even healthcare. People are dropping out of the workforce. They're doing their own thing. They're fatigued. And then you've got the healthcare factors where nurses and doctors are dropping out at unprecedented rates to go do other things or to become contract labor. And those are not only creating challenges to the clinical care models, they're creating economic challenges to institutions, whether you're a medical school, you're a small clinic or a large hospital. All of us are struggling with recruiting, retaining, and maintaining the appropriate levels of staff, and which is a great innovation nidus, right? It's this spark that's saying, okay, well, we need to rethink how care has been provided over the last 30 years. Are the same levels of care, and by that I mean intensity of staffing or staffing models. I by no means am trying to suggest that we can lower the care or lower the staffing provided.
Right.
But like all things, we've had historical models that haven't had to be reviewed, and it's a good time to look at that. It's a good time to reflect and say, are we using our clinicians and professionals and paraprofessionals to the top of their licensure, or have we receded a bit? And again, that goes to the administrative burden. So I think unarguably the number one administrative burden comes from the payer, from a documentation point of view and administration. So there's an easy alignment model that, hey, you could relieve a lot for me, and I in turn then can be more focused on the care that you want. So we can focus on those things, but the real issue is we both have a dependence on nurses and physicians. We both have a dependence on processes that are more manual than automated, as much as everyone wants to assume that everything's wired for sound. And now it's force multiplying initial ideas of saying we need to automate things. It's no longer a we need to, it's we have to, and there's no optionality in it. So, I think our struggles are the same. We're approaching them the same way. And quite frankly, we're both clamoring just to find that one solution in the moment. And it's creating this conversation where it's like, hey, do you have a problem? Yeah, I do. Do you have a problem? Yeah, I do. What can we do? Like, it's almost desperation that's brought us together. I hate to say it that way, but out of that desperation comes a lot of fun conversations, a lot of opportunities, and dare I say it, the opportunity to innovate. And again, a common theme with me is thinking heretically. Innovation doesn't have to be hugely innovative from a technology or bells and whistles point of view. It could simply be doing something that we've been doing the same way for 30 years, slightly different, for the mutual benefit of all parties.
Yeah, what you're saying is that traditionally, historically, when you think about payers and providers, you're thinking, if they're coming down to a negotiation, they're sitting on opposite sides of the table. But now it sounds like what you're saying is the innovation is, look, we're not sitting on opposite sides anymore. We're kind of coming alongside each other and saying, hey, we've got some of these things that are going on. Like, how can we help each other? That in and of itself isn't necessarily groundbreaking, although hasn't probably happened before to the degree that it is happening. And just even having those honest discussions. I know you mentioned about the gamesmanship, and everything is a negotiation, right? There's give and take. But if there's one thing that I've noticed is that relationships matter now more than ever. And when you're moving in that type of a direction, I think there's going to have to be some give and there's going to have to be some take. But man, it's a whole lot better when you actually like the person that's sitting next to you that maybe is wearing a different color jersey, but you're all going for the same goal. Do you find that the majority of the time, the narrative, the vision that you're broadcasting is having to be repeated to different entities and different parties that are involved? Because it just seems as though there isn't just one person that you're going to. This is a multi-stakeholder process, and it obviously takes a little bit of time.
Yeah, that's a great question with good insight. So I'd love to tell you that we've come from opposite ends of the table to the sides of the table. We're eyeballing where we want to sit at the table. I think that's a good thing. But it's because, traditionally these conversations are had at the ultimate C-suite, right? CEO to CEO says we got a partner, and then the expectation is that filters throughout the organization. You're talking about organizations that have 100,000, 200,000, 400,000 employees. So yes, to your point, those conversations have to be repeated. Those conversations have to be top of mind. We have to remind each other to break free from kind of old habits, and old habits die hard. So it's a start, and to be cliche, it is a journey. But unlike a journey in the past, and let's take past me, just prior to COVID, where one side might want innovation or change, and the other side's kind of like, okay, I'm not really wanting to do that. Or one side wants better administration and efficiencies, and the other side's not willing to give. We finally are at a point where we're talking the same. Now, let me be realistic for a moment. You've got, in general, large organizations who are highly successful at doing it the way they've been doing it for decades. To some degree, talk is cheap. You've got to move out of the talk and into the action. And in healthcare, there is a propensity to, when you want to talk about innovation and change, there's a propensity to go to whiz bang technology and data. I mean, we could talk hours on data. Like, really, what have we really done? We're all kind of information rich and insight poor when it comes to data. But I think about partnering with payers and partners in general, not just payers, with simplicity. How do we improve ease and access, right? Because it's very clear, if you don't make it easy to get in, people go to the places that are disfavored and more expensive, right? And it's not good for me as a provider. It's not good for me as a patient or a parent. It's not good for my payer partner. It's a waste in the system. The other thing is, how do I get the patient more involved in the choice of care, site of care, type of care, and the decision making that goes along with it, right? Because I can build a network all day long and we can have copays, but at the end of the day, sometimes irrationality happens. People go to disfavored sites of care. People don't follow up for preventive measures. So bringing the patient more into it, and just no longer assuming that because they have a copay or they have coinsurance, they get it. It's quite complex, even for us that are all in the industry. You can only imagine what it's like for a patient in the worst time. How do you make it affordable and transparent, right? So if I kind of follow these out, I'm making it easier to engage. I'm helping you to engage in the decision making so you have ownership, but I've got to give you the information that matters. And cost and quality and all these great pillars are great, but they're always presented in a way that are subject to bias or subject to perspective, right? And it doesn't help any one of us in terms of how we make those decisions. But on the opposite end of the spectrum, brain surgery is not like buying a toaster or a car. It should never just simply be about what the sticker says. You've really got to connect with somebody. You've got to talk to somebody. And again, that goes back to access and ease. And then I think about the experience, right? I can make it as easy for someone to come in. I can engage you. I can give you all the information. But if the experience is mediocre, that doesn't do anyone any good. And for us, at least, that's our lifeblood. I want someone to come and get care through our physicians, through our sites of care, through our facilities, through our networks. I want them to stay. I want them to be engaged. I want their family to be part of it. And then the final piece is layering in technology and innovation, but layering technology and innovation to achieve those previous 4 or 5 things we talked about. It's kind of like, and you and I talked about this in a previous conversation, it's like what Uber solved for, right? There's a simplicity in this concept of, you want to go from point A to point B, and at least originally, people are going from point A to point B, so how do we connect you all? It's gotten a little more complicated since those original iterations and deployment, but that's the way I view it. The Achilles heel in innovation is just getting people to the right side, getting people to innovate or engage, and all that has to happen before you really innovate. So my view of innovation is the basic blocking and tackling, which is just, again, thematically doing it slightly different, but profoundly different. And that's the approach we take with our payer partners.
Yeah, after all, look, a patient's going to want to get in to see a physician or a mid-level or some clinician relatively quickly. They're going to want to have greater levels of access. When they go in and they see someone, they're going to want to be treated nicely. They're not going to want to be treated poorly. So those things are never going to change regardless of whether we have another global pandemic or not. My question around assessing and prioritizing technology? Because I mean, HCA being as big as it um, is it aligned internally? I mean, to the degree that you're able to talk about this in terms of how technologies are assessed and evaluated, is what does that look like from someone that's on the outside looking in? And then what comments do you have around maybe an early stage company that is even pondering the idea of, having HCA as a dream customer and as real as you want to give it to us, please?
Yeah, yeah, absolutely. Like, I mean, no secret. I think a lot of people understand this. There's two phrases that come up consistently: scope and scale of HCA, and the ability to partner with HCA and then deploy that. Some facts that matter: 200 sites of care. You know, virtually a little less than half the United States, two different countries. Uh, we have 55-ish thousand physicians that are aligned with us. So, I'm fond of saying our business model with physicians are most systems aspirations. We don't employ the majority, about 15% of our physicians are employed. The rest are aligned with us,
Yeah.
not because they have to, because they want to. So if you can kind of come in and get into that environment with a new technology, new product, new medication, whatever the case may be, it's an instant kind of successful environment for you, right? Assuming the care or the device, the technology is the right thing. There's three levels, I think, and there's no science to this. I mean, you can ask five people and you get seven answers. But I think at HCA, my view is there's three levels of kind of technology agenda innovation going on. There's that very futuristic side. What does the next 5 years look like? What do we need to be doing with big partners? You pick the names out there, and I don't mean this in any kind of brand way, but just like the Apples, the Googles, the meta, what can you be doing with big companies? And big companies generally like big companies in partnership. There's the innovation in the moment, like how do I improve upon something? How do I add telemedicine? What's the best telemedicine partner? And then there's the technology that is ongoing, replacement of platforms, integration with new technologies and devices that are just the inevitable changes that go on in healthcare. And those three happen. And I think because of our business model and the acumen of the folks we have, there's fairly good alignment with those. But at the same time, they can and should operate somewhat independent of each other, because you don't want the guy thinking about or the woman thinking about how do I integrate with a particular technology today, worried about somebody saying, well, I'm thinking about 5 years down the road. But those three views of vision have to happen for anybody to be competitive and successful, in my opinion, in healthcare tech. With that said, that often gives people multiple avenues to kind of enter into, right? Are you early stage? Are you knocking it out of the park at some other system and now you're coming to us? Or do you really want to be part of a kind of iteration and a pilot? We're a large organization. It can make or break people almost immediately if successful, but it's bad that it's a large organization, which makes it a little bit difficult because you got to reconcile. We're matrixed organizations. You got to reconcile against multiple leaders, multiple conversations, multiple areas. And then from a structural point of view, we've got corporate, and then we've got all the markets and divisions. And what I've shared with folks is, if you want to be successful at HCA, number one, understand HCA, right? And it's not that we're so nuanced and so different, but understand where our priorities are, understand where our focus is, and ensure that whatever you're doing is consistent with it. It doesn't mean that if it's not consistent or not applicable, we're not going to consider it. But the easiest kinds of successes, or the most rapid adoption of interest, comes from the things that are immediately aligned with where we're going and how we're doing it. The second thing is to kind of understand the landscape, and it's almost a pincer move. I like to refer to that. We're not a company that just takes things at corporate and pushes it out. There's got to be buy-in. There's a balance. So if you can get local buy-in, but recognize there also at some point needs to be corporate view of the world, then you've got both sides acting in tandem. And so, if you've talked to HCA, you've talked to HCA, meaning there's lots of entry points and lots of conversations. But it is to think through that. To know HCA is to also understand the structure and who am I talking to, how am I talking. The final piece is just to have patience with us. We are very deliberative. We are very complex. We allow the executives to opine. Again, we're not a push down or one person says it all. And that can be very off-putting to a lot of folks. It's not uncommon for conversations to take 6 months or a year plus. That's not a lack of interest. It's not even a disinterest and we're just kind of slow. It's just the nature of getting all the right people together, because we're also interested in making sure we have the most efficient conversations as possible. But it's amazing, and you know this well, I'm sure, that when you're starting out or a young company, there's an aggressive nature. There's a tendency to want to, ping people more often than not, and that doesn't work to their advantage. And it's particularly so here, again, not because we're going to be passive aggressive. It's you can't force and artificially get us to do it differently. The lesson learned is when that does happen, it tends to backfire because we miss an important piece, or we alienate important decision makers. And so those are the three things I would say to folks: is kind of know where you fit into the life cycle, and from an agenda and a technology point of view, understand what we're trying to do and our organization and our footprint and how you're going about navigating it, and then to have that ultimate patience with it. And there comes to be critical decisions with that. I've often said to folks that we can make or break you, right? If you're an early startup and you're hinging everything on HCA, and you may not have the year and a half or 2 years or whatever the timeline is, you may want to come back to it. But we're also a company that values if somebody has a proven track record. And now it's like, hey, I did this pilot with organization X. I want to come to you and deploy with you, HCA. That takes a lot of the heavy lifting off of us. So there's a strategy behind it, as you can imagine, but there's also an art to navigating within a large organization such as ours.
I mean, you said it earlier. You said that you're a payer guy and you are in an IDN. So you think about it from the lens of being a payer. And I'd say probably that same level of advice is probably applicable to an earlier stage startup: is put yourself in the shoes of what it looks like to be an executive in a large IDN, and then figure out where is what you're solving rank in their world, not in your world, because in their world or my world, everything's number one, right? Everything's number one. In your world, it could be, number 55. And no wonder why you're not responding to my email. It's like, because this is not within my top 5, and I only have a certain focus that I can of initiatives and rocks I need to get done. If this isn't within those, then I'm sorry, but you're gonna have to take a little bit of a back seat. So, words of wisdom there. Really appreciate it. Any other projects, things that you're working on that you think are really interesting, really cool, that you're excited about, things that you can obviously share, with the general public?
Yeah, I mean, I'll be very general. I do want to come back to something you said in just a second, but I'm excited for some really great opportunities in behavioral health. Really innovating in how networks get built, looking at national networks of behavioral health and integrating with those on the outpatient side. As you may know, HCA has a very strong inpatient footprint in behavioral health, but we, like others, struggle with outpatient. That's the thing, and this is an area where we can come in with the right partners and the right design and enhance existing payer networks with very little change to either party. So it's a really great opportunity. There's that opportunity of thinking through episodes of care that we naturally provide: women's health, orthopedics. How do we engage differently in that space? Again, less service line and more centered around a solution for back pain, a solution for knee pain, if you will, and really have this trite phrase. Most people talk about centers of excellence, but we could provide a network of excellence, and we can provide an ecosystem with optionality inside of care. So again, really thinking about what's out there and saying, as HCA, we can take the existing and change it in a way. And again, we're not talking about a bunch of technology. We're not talking about a bunch of labs and those kinds of things. It's really just retooling how people view what a network is or how access. But I do want to come back to something you said. What I have noticed in my role is most often than not, as you said, people, their livelihood of their product, their thing is their priority, but they never really get past the good idea. They don't go, okay, and it sounds self-serving, but it really isn't. Most people come to a hospital, it's kind of like the guy who robbed the banks. Why do you rob banks? Because that's where the money is. And they go, well, I'm going to hospitals because that's where the funds are. And that's not the way it works. Most things that go to a hospital system are really just expenses to us, or things that are an expense with the promise of helping us be more efficient or possibly generating more revenue. And folks come to the table with those kinds of pitches without any idea of the landscape of how reimbursement really works. And so it's not, again, that we're disinterested or people become passive aggressive. It's there's a disconnect between what someone is saying and what the reality is. And then the second piece is a lot of great ideas stop with the clinical great idea and really should continue with the commercialization. What is your reimbursement model for this? What's your strategy to get payer adoption? Have you even thought about that? And you'll be amazed at, regardless of what it is, how people come to the table with, it's a good idea, but I haven't talked to any of the other stuff. And it evokes a sense of immaturity in the healthcare space. And unfortunately, that penalizes a lot of folks. And they may have great ideas, but again, this is a world where great ideas have to be funded by somebody, and particularly the payer partners, and where people kind of stop their strategy and innovation is with, I created it, but they don't really think through the use of it and the deployment of it and the payment of it. So it's kind of a comment and advice, kind of two things is to understand the ecosystem by which one is pitching in, and then to also understand that the first thing we're going to think about is, okay, if it's great and it does what it does, how's it going to create revenue or more patients for us? And it can't be this hope and promise that, hey, if you're better, outcomes improve. Sure, outcomes in the general improve, the world does better, but it's disproportionate as to whose world does better and what time. So just a little bit of advice on that.
What do you rank higher? The generating revenue, a solution that generates revenue, or a solution that saves money, or one that does both, ideally?
Yeah, it's hard to say. It depends. To be honest, I don't mean to vacillate on there. There are, and we're very public about wanting to be very efficient with resources and funds. And we, Sam Hazen several years ago embarked on a corporate initiative to really be fiscal stewards or in terms of cost. So it's always going to be a great thing for hospitals who generally are paid by fixed amounts in the general DRG to be very efficient. And something that comes in and says, I can replace, reduce, or cut costs by a certain amount, that's a great conversation. It's equally important if someone can come in and say, I can improve outcomes. Improving outcomes, though, and I guess this goes to my previous comment, improving outcomes, and I just had this conversation with a payer an hour ago, that's great. And that is what we all strive for. Above all else, care and improvement of human life is our mission. But I can improve an outcome to my detriment. I can reduce hospital days. I can reduce, a site of care, but it's to my detriment, and it's an automatic improvement to the payer, but it doesn't mean they value it in a way that it comes back to me to help me become an operational activity. So I guess what I'm saying is I listen to myself aloud. If I had to prioritize, and I'm basically, kind of Sophie's choice, what hand do you like, your right hand, left hand? I like them both. But I would say something that comes in with expense management and then can do quality improvement is going to be highly valued over something that does either one alone.
Makes total sense. And to your point, the jury's not out yet, right? There's going to be, my hunch is that there are going to be quite a few startups that make assertions that haven't been fully vetted, fully validated, and they go on, they start companies, and the next thing you know, you start to see a lot of them that aren't going to be here in a year or two from now, and it's because they've made those assumptions. So your point is well taken. So for those that are tuning in, that's just you heard it from the source. What's the best way for folks to, I guess, keep in contact with HCA, follow your work? I mean, I guess just a plug on HCA and things that people need to know.
Yeah, I mean, I love for people to reach out to me directly. I love having conversations and thinking through, what are they doing? How does it relate to what we're doing? How does it influence what we should be thinking about? So I'd say, people can reach out to me directly through my email or my phone number. I'm happy to give that out in whatever format makes sense. I'm also
yeah, we'll put it in the description. We'll just have people kind of ping you on social media. We're not trying to give out your personal email here, but
no worries.
Otherwise, you might be getting some people reaching out. But,
that's right. Yeah. Michael said, reach out. Okay, great, fantastic.
Yeah, great. Thanks. You've been reaching out to me, telling me what the hell's going on here.
The point being, I appreciate that. The point being is I'm fairly accessible. I'm not, an ivory tower kind of guy, but I'm on social media. Well, I'm on LinkedIn, but among all the modalities, the best way to get in touch with me is drop me a line. And if I'm not the right guy, I'm the right guy that will connect people. I like to connect people. I like good ideas. Happy to talk to people, spitball, whatever the case may be. But fairly approachable. LinkedIn, social media, or directly. Those are the best ways to get me. Every now and then you may see me on the speakers bureau or the speakers circuit, but quite frankly, I'm here most days, more often than not.
Well, this has been really fun, Dr. Shah. Is there any one takeaway, one golden nugget that you want the audience to kind of take away and put into action? Because at the end of the day, ideas make you feel good, but really only actions make things happen. And if so, what's that one thing that you want to kind of put your finger on?
Yeah, hard to really say about. I'll say this with the intended audience in mind. If specifically for those who are interested in connecting and partnering with HCA, just go into it with a recognition that what you have will work with about 95% of HCA. There's going to be a 5-10% that needs to be tweaked just because of who we are, our model, our thing. And that could be a hard 5 or 10%, but just to be prepared for that.
Awesome. Well, folks, you heard it. Dr. Shah, thank you so much. And if you found this content helpful for you, would you mind sharing it on social media, engaging with it, commenting on it? I'm so grateful when we have great guests that come on, but then when we have more people that are coming into the community that actually really want to make a difference, want to advance healthcare forward, want to have that alignment. And we need more doers in the community. And it really kind of starts from here. So Dr. Shah, we're looking forward to connecting with you at some point in the future. And thanks again for all that you've done.
Thanks, Michael. I really appreciate the time.
You bet.